Greetings, everybody, and happy summer. I hope everybody's had a wonderful time over the last 8 weeks or so since we've been together. I hope you've gotten away, had a little cool weather, spent some nice time with family and loved ones. And here we are now, getting back to fall and getting back to school in session. As always, I want to thank our Society for Leading Medicine for all of their great support, Jeremy and Caroline, Catherine and George for their leadership. Thank you, all of you, for that tremendous, palpable support for Houston Methodist. You know, I think almost all schools, if not all around town, have gone back into session over the last week, so we thought it would be a great time to talk about topics around school safety and around our kids' safety as they go back to school. Now, unlike when we do kind of urology or women's health or some other topic where we have kind of a resident expert on the chat, we don't really have a resident expert. We've got them all right here. And so there's not a chat today. If you do have questions, please text them to us. You can text the word DeBakey to 37607. We're going to talk about some very interesting topics today, including school bullying from Dr. Marianne Carlson. We're going to talk about immunizations and a little bit on monkeypox, since it's a hot topic, with Dr. Ashley Drews, who you all know very well. And Dr. Ken Podell is going to talk to us about concussions and sports injuries. Now, we plan these events well in advance, and of course plan this one to time with school. I think Dr. Podell's talk today is particularly poignant. Unfortunately, we lost two individuals this week on the same day who've been instrumental to our concussion awareness and prevention. Both members of the PLC, both members of our Brain and Bone Collaborative. Randy Nelson died unexpectedly while out of the country, one of the most kind-hearted people I've ever met, a very accomplished international executive. And Jamie Roots, a very good friend of mine. We served on the United Way board together. We served on the Greater Houston Partnership together. He was former chair, and I'm following in his footsteps. Members of YPO together, and of course with his leadership with the Houston Texans and everything we've done together working on concussions and physicals for young athletes. Really a tremendous friend of Houston Methodist. His wife, Melissa, when announcing his passing, talked about the fact that he had suffered from mental health issues, and so it's especially poignant today. Dr. Podell is going to talk to us about teen mental health as part of his topic as well. Please keep both of them, their families, their loved ones, their friends in your prayers. And we are so grateful to each of them for everything they've done for our community and for Houston Methodist. Tremendous losses in both cases. God bless each of them, and may they rest in peace. So we're going to start now with Dr. Podell. And I'm going to turn to Dr. Podell, and very eager to hear all about concussions and keeping sports athletes well, and some of the mental health topics you're talking about for our teens. Thank you for being here.
Thanks, Dr. Boom. Thanks, everyone, for being here as part of our town hall. It's great to be here, and two topics I'm going to talk about today, concussions and teen mental health. Both are very, very important to me, and when we get to teen mental health, you'll see why it's become such an important issue for all of us, including our community. As we're going to start with concussions, one of the things I do want to say is concussion is a form of traumatic brain injury, where individuals, it's a mild form of traumatic brain injury, and a concussion is defined by a traumatic blow to the head or the body that causes a disruption in brain functioning. This disruption is typically a chemical or metabolic disruption. And typically, symptoms start almost immediately. Sometimes there could be a little bit delay of a few hours, but you will see the effects of the concussions soon after that hit occurs. Usually, we kind of estimate about 4 million concussions occur in the U.S. each year. It's an estimate because a lot of head injuries go unreported. And there is about 90% of concussions do not have loss of consciousness, and that's a little bit of a misconception where people think that you need to be knocked out in order to have a concussion. And actually, it's not the case. And typically, if there's loss of consciousness, it's only for a few seconds, very, very brief. And when we talk about concussions, at least at the high school level in team sports, about 8% of all injuries reported in high school sports are concussion related. If we step back and look at the general pediatric population, what you'll see is between the ages of 6 and 17, about 10% of the kids will be diagnosed with a concussion in a given year, and this data is mostly from 2020. From 12 to 17, middle school, high school, it's about 8% again, but you can see about 10% of our kids will sustain a concussion. Now, one of the things to understand is how it occurs, and the brain is the softest tissue in the human body and literally has the consistency of cold jello. So it wiggles a lot and it can move. So when there's movement of the head and it suddenly stops as two players hitting or hitting the ground, the brain kind of jiggles around, for lack of a better medical term, and that distorts the shape of the brain, and that causes the cells to kind of lose its functions a little bit, and that leads to that chemical imbalance in the brain. Some of the symptoms that you'll see with concussions, there's a lot of them, but headache is the most common. But you'll see things like headache, sensitivity to light and sound, sometimes dizziness with nausea. Fatigue is a very common one. Feeling confused, foggy is a common word that people use to describe some of the symptoms in concussions, as well as irritability. Sometimes kids can get very, very irritable. So if you think your teenager is irritable now, wait till they have a concussion. The irritability can go up a little bit more. And the other things to remember is our female athletes. Females are more likely to get a concussion than a male in kind of the same sport. And number two, their symptoms tend to be a little bit worse, and it can take them a little bit longer to recover from the concussion. So we do pay special attention to our female athletes. This is actually my favorite slide, and because it really encompasses concussion. Concussion is more than just a brain injury. It affects a lot of different parts of the body. It can affect your neck, your eye movements, your balance system, something we call autonomic system, which controls your heart rate, your temperature regulations. All of these can be affected. And when we do a comprehensive concussion eval, we're looking at all of these to see what system got affected by that concussion. It's a very individual type of injury. And by knowing what's affected, we can treat it sooner. Concussions are treatable. And knowing what's wrong, we can start the treatments earlier and get the individual better faster. Now, if you do suspect that family members had a concussion, your child's had a concussion, it's very important that we monitor them for a few hours. Right? We want to know what their symptoms are doing over time, and 2-3 hours is typically the amount of time that we want to monitor them. Never ever give aspirin. Aspirin's a blood thinner, and we don't want to do that with any potential head injury. If they need something for pain initially, it's going to be Tylenol only. No ibuprofen, no naproxen, that's Motrin, that's Aleve, that's Advil. We do want to hold off on those for at least the first 48 hours. After that, we can start using that if needed. If your child is doing okay, no change in the symptoms, they're getting a little bit better, they can sleep. They might want to sleep, and it's okay to let them sleep. You don't have to wake them up in the middle of the night to check on them anymore. Let them sleep through the night. Keep them hydrated. It's very, very important to keep them hydrated. They may not want to eat much, so if you can get them to eat a little bit, that's okay. If not, that's fine, but please try to keep them hydrated. In terms of recovery, we like to think of it as active recovery, and we will rest them briefly for up to 72 hours. It all depends how they're feeling, but we don't like to keep them in a dark room anymore. We want to just let them move around a little bit, remove irritants. So if screens bother them, then stay off the screens a little bit, loud noises, but we do want to keep them rested for the first 48 to 72 hours. After that, it's a Goldilocks approach, not too little and not too much activity. And that goes for physical and cognitive activities. They may miss a day or two of school. If they truly have a concussion, letting them sit in a class where they're mentally foggy, they don't have good memory, doesn't help them. And so actually it might be better to keep them home a day or two initially. And as we start progressing them, we do a little cognitive activity, a little physical activity, and kind of slowly work them back to their normal process. In terms of school, that's the most important thing for our kids, is getting them back to school. We do have a return to learn program where it's 5 steps of gradually getting them back to school. No homework at first, no tests, no quizzes, no assignments, and then gradually start to increase that over time. If your child plays a school sport, they need to be back to academics prior to returning to their team sport. To me, that's a very, very important type of thing. In terms of prevention, we have 4 things to talk about. Education is the most important thing. Your child needs to know what a concussion is. They need to know the symptoms of concussions. That's very, very critical. If they know that, when they do get one, they will know that they need to remove themselves from that sport activity. Children who continue to practice or participate in a competition while concussed are at risk of a more severe brain injury and are more likely to take longer to recover. The research kind of suggests twice as long to recover from that concussion. Proper equipment is very, very important depending on the sport. Virginia Tech has a website that's listed here that does a very good job of reviewing helmets and the safety of the helmets and reducing concussions. It is independent, it is not funded by anybody, so it is truly objective data. And always remember, the most expensive helmet is not always the best helmet out there. Proper technique. It's important to teach the proper technique, which reduces neck injuries and concussions as well. Neck strengthening. We find neck strengthening very important, particularly with our younger athletes that might have a little bit bigger head and a thinner neck. That's pretty prominent for our female athletes. Strengthening the neck can reduce, obviously, neck injuries as well as concussions. Now, if I can, I'm going to transition to mental health in our teens and adolescents. This is my 30th year of practice, and in the last 3 years, I dealt more with mental health issues in my practice than I have in the 27 years before. And it's become a very, very important issue for me professionally and personally with what's happened in the community. So I do want to address this issue with everyone here. The American Academy of Pediatrics and American Academy of Child and Adolescent Psychiatry have a declaration of a national emergency in our child and adolescent mental health. It is considered a crisis among many professionals, where we are seeing very high rates of depression, anxiety, emotional trauma, loneliness, and suicidality in our youngest populations, of our youngest kids, our adolescents and teens. The trend was there before COVID, and COVID has significantly increased that rate in all of these areas. And I do want to show you that a little bit. For example, suicide is considered the 3rd leading cause of death in teenagers and adolescents. 3rd leading cause. In college students, it's the 2nd leading cause of death in our college students now. And suicide, and this is before COVID, suicide rate increased by almost 60% in 10 to 24-year-old individuals between 2007 and 2018, okay? And you'll see since COVID, it's gone even higher. And this one is kind of startling a little bit, is 5-fold increase in suicide attempts in 10 to 12-year-olds. 10 to 12-year-olds, and these have been vetted, so they are probably true suicide attempts. And usually it's overdose on chemicals around the household that tend to be it. 2013, 2019, 20% of teens experienced an episode of major depression. About 25% of females in the middle school and high school ages report having depressive episodes in the past year. And this one, to me, will be a significant spark in increasing mental health issues in our children, is that since COVID in the US, 200,000 children have lost a parent or a primary caregiver due to COVID. And that likely will increase stress and anxiety and depression in our youngest population. Now, since COVID, this study came out last year. If you take a month in 2021, in early 2021, at kind of the height of it, of COVID, there was a 50% increase in suicide attempts in females between the ages of 12 and 17 compared to the same month in 2019 before COVID. So the increase is actually even higher post-COVID. So the question is why? And here's a little bit of a diagram that I put together. It is very, very hard to be an adolescent and a teen today, okay, and compared to when I was growing up or something like that. They have pandemics, they have school shootings, they have climate disasters. Social media is through the roof, and it's often negative, particularly for our female adolescents. Peer pressure, online learning works for some, doesn't work for a lot. So less sleep, when teens are sleeping less, all of these are factors that fuel depression and anxiety and suicidality. So it's something that we really, really need to work with and figure it out. Here's something from the National Institute of Mental Health that you can go online and look at, and it's just warning signs of suicide. And things to look for. Very sad. Talking about death, talking about poor self-esteem. If your child starts giving away things, starts to say goodbye, if they're looking online about how to harm themselves, these are major red flags that need to be taken seriously, and immediate action needs to be taken. You can work ways of preventing this a little bit by working with your child in developing coping and problem solving skills, teaching your child to think through problems and understand it, maybe writing down how they're feeling so they can read it and look at it a little bit more objectively. Support from religious, social communities, school groups, all of this helps. One of the most important things for our kids is to lock it up. I can't stress this enough. Guns, medication, alcohol, and chemicals. Okay? Access to guns has always been the #1 leading cause of attempted suicide. And these things need to be, and even chemicals, because if our younger kids, 10 to 12, if they have access to it, that is a risk factor. The other thing to do is you need to listen first and then talk. You have to be non-judgmental. You need to hear what your child is telling you. You have to validate what they're saying. It is truly how they're feeling. You can't dismiss it, you can't judge it, and you can't tell them everything's going to be okay. You listen first, hear what they're saying, and then start the problem-solving process with them. Do not judge them. Seek professional help. There is nothing wrong with finding a clinical psychologist, a psychiatrist, your pediatrician to help. If your child had a knee injury, if they had a rash, if they had a fever, you would seek professional help. Same goes for depression, anxiety, and suicidality. 988, remember that number. That is now the National Suicide Prevention Hotline. No more 800 number, it's 9888. It's similar to 911. Add 741-741 to your children's phone, okay? It is a number that they can text to get professional help. Houston area has a hotline, general number and one specific for teens, and they have a text. Add that text number to your child's phone. This gives them access. They don't like to call, okay? They like to text. Use that as their preferred method. And over here I did list some community resources that we do have available to us in Houston. So with that, I will end, and I do thank you for your time.
Well, thank you very much, Dr. Podell. Some sobering statistics for sure, and we'll talk some more about that in the discussion time. We have Dr. Marianne Carlson here to talk to us about school bullying, which of course is also a topic that many times will be linked to mental health issues. So Dr. Carlson, thank you for being here to talk about that.
Thank you, Dr. Boone. Like we're talking about, it is back to school, and all of us have been back to school before. You might remember the anxieties and the insecurities that you felt walking into the school doors on that first day. Will the cool girl like me? Will they let me sit at the lunch table? Should I listen to my mom and be nice to that person? These are some things that we might have thought and experienced when we were school-aged. And similarly, we might have experienced bullying. We might have either seen it firsthand, or we all have an understanding of what bullying is. But in our culture today, it's new and it's evolving. Bullying looks very different, and it's growing in its prevalence and its impact. So as our kids are going back to school, we have a responsibility here on a few different levels. First, we need to be aware of the type of environment our kids are walking into each day. We need to have an understanding of the types of struggles and pressures and influences that they're uniquely experiencing. That will help us ask the right questions. It will help us connect with them in more meaningful ways. And secondly, as parents and grandparents and community members, we have a responsibility to be models to our kids of what healthy, respectful, civil relationships and interactions look like, particularly around differences. Our kids are looking at us. They're taking cues from us. We are their models. We know that adults, administrators, teachers, staff, family, we have an influence on the way our students behave towards one another and relate to themselves. So we want to keep that in mind as we're thinking about bullying. I'll briefly define bullying. I think we all have an awareness of what it is, but particularly focusing on cyberbullying, which I would say is it's at a fever pitch level right now in the ways that it's affecting our kids. We'll talk a little bit about the impact, the deep impact holistically that bullying can have on our kids. And hopefully practically we'll get to what do we do? How do we intervene? How do we help? And ultimately, how do we cultivate resiliency in our kids? So the prevalence is very large. About 1 in 4 students are being bullied. And we know that about 40% of the time, kids aren't speaking up and telling each other and telling adults that they are being bullied. We have a really big problem that's likely an underestimation for the 1 in 4 students. We have a really big problem, and we often aren't aware that it's going on. And when we do find out that it's happening, sometimes we either minimize it or say, oh, it's okay, it's not a big deal, or we don't really know how to intervene. One of the things that historically people have focused on when it comes to bullying is the victim and the bully. But I want us to also think about the bystander. And the bystander is really a broad term, and it's the audience. It's the social context that the bullying's occurring in. And the bystander can be the friends, the peer group, the teacher, the administrator, the family, the social media person that's just watching the interaction happening. And the bystander really has a responsibility to speak up. And we see that often doesn't happen. And they play an active role in reducing bullying. And they help us create what we call a school climate or a school culture. We know that students are influenced by their environment. We're all influenced by our culture. So the type of environment they're entering into each day, the norms and rules associated with the culture, has a direct impact on the extent of bullying that takes place in a school. So we want to create a culture of upstanding, which means speaking up, saying when you see something happening, saying when you know bullying's occurring, encouraging all bystanders to speak up. That also includes us. Encouraging respect, healthy relationships. This is what we know ideally and ultimately reduces bullying. So practically, this can look like a few different things. I know for me as a mom, as I'm thinking about where am I sending my son to school, what do the academic outcomes look like, or maybe what do the sports programs look like? I want us to also consider what is the school climate? How safe is the school? What is the culture of the school? Is it physically safe? Is it socially and emotionally safe? How are they promoting respectful relationships? Do teachers have social support? The more support they have, the more they're able to pay attention to the things that are happening in the classroom, like bullying. Do the students feel connected? How does the leadership talk about pro-social behavior, respect, understanding differences, paying attention to really a top-down type of environment that's created in a school? Are they providing mental health and risk prevention? These are questions that we should be asking and wondering about. Asking the administrator, asking teachers, asking parents, really understanding what type of school climate is my child going to be entering into, because this has a direct link to reduction in bullying. Of course, we know, again, what bullying is, but the two main tenets that I want to pull out and really highlight that the Texas Education Code actually uses as more of a guideline for what bullying is there's typically an imbalance of power, and there's typically an intention to harm. And so those are things that they're really looking for when they think, what is bullying? Does this meet the threshold for bullying, and should we intervene? There are often many different types of bullying. The one that I really want to highlight is cyberbullying. It's at a fever pitch level right now. Our kids can't get away from it. And the difficulty with cyberbullying, I know this really wasn't a problem when I was growing up. I don't know if we are really familiar in the ins and outs of cyberbullying, and it's something that we really need to be aware of, because you can't turn off the technology. Even when you put the phone away, even when the computer shut down, things are still being said, things are still being put out there. Additionally, you can't erase the pictures. You can't get rid of the rumors. You can't get rid of the things that are written. Once it's out there, it's there to stay. And that can really make our kids feel hopeless and powerless and feel like they don't know what to do or how to get away from it. And like Dr. Podell was saying, and beautifully said, this is having a profound impact on our kids, physically, emotionally, socially, and behaviorally. He talked very, very wonderfully about the emotional impact that we're seeing. We see that in a very real way right now in the Department of Psychiatry and Behavioral Health. Our young adults are struggling. Our kids are struggling. Some things just to keep in mind and look out for, like the physical, the cuts, the bruises, the headaches, the stomach aches. Those might be some red flags of, what's going on with my kid? What might be happening in the schoolyard or while they're away? Emotionally, looking out for the things that Dr. Podell talked about. So I won't go into that in more detail, but just know that bullying has a connection here to a deep, profound emotional impact, and it's really shaping how our kids view themselves and how they relate to the world. Socially, we'll see more isolating, more feelings of disconnection and disconnectedness. And behaviorally, we know that, like, quite practically, kids can't learn when they don't feel safe, whether that's psychologically safe or physically safe. It's hard to concentrate, it's hard to take in information, and they quite frankly might not want to go to school. So we see academic performance really suffering and struggling with bullying occurring. So if you're like me, you might think, gosh, this is such a huge problem. What the heck do I even do here? I think first and foremost, we need to be aware. So something like this, where we're hearing it, it's on our radar. We know this is an issue, and we know it's a pervasive issue and a really serious issue that our kids are going through daily. We need to be informed. We need to know really specifically and uniquely how our kids might be struggling. Additionally, know the policies in your school. In Houston, the public schools and the private schools all have very specific policies for how bullying is handled and what can be done and how intervention can be maintained when bullying occurs. Also, there are laws that protect against discrimination, harassment, cyberbullying. David's Law specifically protects our kids against cyberbullying. So know that there actually is legal intervention that can occur when it becomes to a certain threshold. I think the most important thing that I hope you leave with today is my last 2 points, and it really links nicely with Dr. Podell and what he was talking about. Because ultimately what we're talking about here is relationships. We're talking about how people relate to one another and relate to themselves. We know that as parents, the quantity of time that we spend with our kids is actually not as important as the quality of time that we spend with our kids. And quality of time is not just happy, fun time. It's actually the time that we spend being thinking partners with them in the midst of difficulty. And so being a person that is trustworthy, reliable, dependable, that they know that they can come to, that really helps with the 40% that aren't speaking up. They actually know that they have someone they can turn to. So being that consistent, trusted adult for them is extremely important. And when they do come to you, being a listener, helping them understand what's going on for them, that's this being curious. There's a $5 word for it called mentalization. So how do we understand our thoughts, our feelings, the motivations inside of us, and how do we understand what might be going on for the other person? So as parents, helping ask those questions and create that curiosity in a non-judgmental, empathic way. And ultimately, what cultivates resiliency is these foundational types of interactions with our kids. To be a thinking partner with them when they are struggling means not taking away the struggle, not making it so that they're not struggling, because that realistically we can't do that. We can't solve for everything. Even as a mom, I wish that I could. I don't want my kid to struggle. But actually joining with them and walking alongside of them, helping them problem solve, helping them think through things, helping them understand their own internal resources so that they can initiate right behavior and right action. These are the foundations for resiliency, and these are the foundations for healthy, more emotionally resilient kids. And ultimately, if we're able to walk alongside our kids while doing this, the goal is, and I think ultimately they'll be better able to speak up, they'll be better able to speak out, and they'll be able to navigate these challenges in a better way. These are a few just quick resources that I think would be really helpful for people to look at. If you're a little bored on a Friday night, read through the Texas Education Code. And there's a few other sites here that are really helpful for understanding our schools and our school systems and what you might do for bullying. So thank you.
Thank you very much. So, it strikes me, one of the things we often talk about at Houston Methodist is our strong culture, and how a culture is not something, it can be something that just happens by accident. It's also something you can shape, model, direct, kind of keep within bounds and other things. So I'm really interested in your conversation about the schools, because it seems to me that kind of very purposeful approach to create the right environment and culture is critically important at schools. So give us some examples of how schools should do that, and I guess how parents maybe can encourage their schools, especially if they're seeing an issue.
Mm-hmm. Yeah, I think the first thing to actually talk about is maybe like what not to do. So actually in the 80s, we really made a push for the zero tolerance policy for bullying, a very punitive type of culture and environment, and we actually saw an increase in bullying, or actually a lack of reduction of bullying. And so that culture was a very punitive and unhelpful culture. So changing from the top down the way that we think about speaking up and that upstanding idea. So one of the studies that has been shown to be really helpful in reducing bullying, their administration is talking about it quite often. Their administration and their teachers are trained on this mentalizing, this curiosity, this understanding the internal world of themselves and other people. Their signs, they're talking about it in the schools, it's in the hallway, they're making time for how we're relating in healthy ways, and they're giving students opportunities to speak up. So you really see this whole school environment needs to be bought in and needs to, from the top down, have some buy-in for creating a school culture of reducing bullying.
Gosh, the parallels I see with everything we do around culture, around safety and speaking up for safety and all those kinds of things in the hospital industry and healthcare and that, I mean, they're pretty significant. I've got a lot of questions on that, but I need to move us on, and we'll have some time a little bit later. I've got Dr. Ashley Drews here now, who's going to talk about childhood immunizations and immunizations for back to school, and probably throw a little monkeypox in there for fun. Why not today as well? So.
Yes, why not? So I want to start talking about immunizations, which are very important and topical with back to school. And then we'll talk about monkeypox, because it's just such a hot topic in the community, but hopefully is not as relevant to the back to school effect. So starting with immunizations, I wanted to share with you, these are the minimum state vaccine requirements for students in Texas. And you'll see that there really are just 7 vaccines that are required for our students. So, they have to have DTP, they have to have polio, MMR, they also need to have, excuse me, it's hard to see here, varicella vaccine in order to return to school. And so these are the requirements that they have, and they're a minimum. And thank you. Some of us have older eyes. This is important for us to see. And I wanted to also say, for students that are entering college, some of us have older children. And there is just one vaccine that is required in the state of Texas for our students to go to college, and that is the Meningococcal Vaccine because of the high risk in that congregate setting. So all students are required to show proof of the Meningococcal Vaccine prior to going to college here in the state of Texas. So, and this is in stark contrast to, these are the recommended, all pediatricians are very familiar with this table. Those of us who take our children into the pediatrician for their vaccines have all seen this table. And you'll see there are a whole slew of vaccines that are recommended for children and for their health. And not all of them are required to attend school. So you'll see that many vaccines that are actually really helpful for our kids, the rotavirus vaccine, flu shot, pneumococcal vaccine, Haemophilus, those are really important for their health, but are not required. There's really just a very minimum number of vaccines that are required to attend school. And you'll see that COVID-19 vaccines are not required to attend school. They're not even on that ACIP list. But ACIP does recommend COVID-19 vaccines for everybody who's age 6 months and older. And it's just an important reminder that you can give them on the same day as any other shot. So kids, when they're going for their other vaccines, can also get COVID vaccines. This is just a quick reminder. This isn't necessarily back to school, but as an ID doctor, I could never skip over this. As adults, we are also not immune to getting immunizations. There is the recommended schedule for us as adults. And so just because we're not going back to school, we should also be seeing our physicians and getting our vaccines. You know, really, vaccine preventable diseases is the biggest, health achievement that we've had in our century, and don't want to lose that. So adults should also be getting their immunizations on schedule. So wanted to touch a little bit, just because all those vaccines are recommended and even required for back to school, not all students are vaccinated and certainly haven't received all of those vaccines. And what happens? So there are certain exemptions that you can have for vaccines. There are medical exemptions. And these are for kids that have a valid medical contraindication to a vaccine or its component. So like they could have anaphylaxis to the vaccine. There are religious exemptions for people whose religious beliefs oppose the vaccination, or philosophical exemptions. Some individuals who may have a personal, moral, or philosophical belief against some or all immunizations. So I wanted to let y'all know that the exemptions that are permitted to school and child care really vary by states. And you'll see that not all states have the same exemptions. You'll see in Texas, we are one of the most permissive. The states that are in green have medical, religious, and personal exemptions that are allowed. The states that are in that lavender color have medical and religious exemptions. Those in the salmon, just Minnesota and Louisiana, have exemptions for medical and personal belief. And in white, there are a handful of states that allow medical exemptions only. And it does make a difference. The vaccination rates in communities are inversely related to how easy it is to get exemptions. So the states that allow religious and philosophical exemptions in addition to the medical exemptions do have higher exemption rates than the states that allow only religious exemptions, and higher than those that allow only medical exemptions. Also, they have higher rates of vaccine preventable diseases, so it is really important. All of these societies, the American Academy of Pediatrics, the Pediatric ID Society, the Infectious Disease Society of America, the American Academy of Family Practice, and the American Medical Association all support elimination of non-medical exemptions for immunizations. It's really, really important. And I would say a corollary to that is that it's important that medical exemptions are really true and accurate. For example, the state of California, when they went to having medical exemptions only, they saw in 1 year a stark increase in the number of medical exemptions once they got rid of the option for religious exemptions. So really want to make sure that they are true and valid. So how do we compare in the state of Texas? As I said, we are more permissive in allowing all of those exemptions. And you'll see that we in Texas are in the light blue, and the nation, U.S. National rates are in the darker blue. And then for several of the vaccines, you'll see in green really what the healthy people 2030, what the target is. And you'll see that for all the vaccines in Texas, we are lower than the national average and really not there. We're pretty close for MMR. We're further off for the DTP and flu and for the HPV vaccine. So being more permissive, we are not achieving the same rate of protection for our children in our state. And so what does this relate to? You know, we've all talked about vaccine hesitancy. I think a little bit more with the COVID vaccine has come more to the forefront. And it is really a delay in the acceptance or the complete refusal of vaccination despite the availability of vaccines. So it can be influenced by complacency, and so that is the perception that the risk of the vaccine preventable disease is low. It can be obviously influenced by convenience, if the availability, the affordability, and accessibility of the vaccines, and by confidence. So really, the people who are accepting the vaccines have to have trust in the safety and effectiveness of the vaccines, the healthcare system in general, and the policymakers and the physicians who are recommending those vaccines. So all of those things are really, really important. So there are lots of reasons that parents refuse vaccines. They have some safety concerns. Some of them are legitimate. I mean, there are side effects to vaccines that are important. It's just important for people to know the relative risk and how that applies to the risk of the disease itself. And you know, the weights of those. Some parents actually believe that the vaccines don't work, or they believe that their child is really not at risk for the disease that the vaccine is meant to prevent. They believe that that vaccine preventable disease is not dangerous, or some parents will believe that it's really just better for their child to be naturally infected than vaccinated. There's a strong belief by some that really they know what's best for their child and that they should have the right to make decisions for their child. Some people refuse vaccines due to just lack of trust in the government, public health authorities, and pharmaceutical companies, or on the basis of religious or moral objections. And so does this matter if kids are not vaccinated, and what happens when our vaccination rates are low? I think that we've all heard about polio in the state of New York, and that was the first U.S. polio case in nearly a decade. And obviously really concerning. The picture here is back from the polio outbreak in the 50s, and you'll see kids in iron lungs. Fortunately, you know, that is not how we would have to treat it now, but it is really a reminder of the severity and gravity of vaccine preventable diseases. And so there are consequences of vaccine hesitancy and low vaccination rates to the individual who is not vaccinated. Obviously, they have a greater risk of acquiring that vaccine preventable disease because they're not personally protected. Even if they delay getting the vaccine, then they have a higher risk of getting that vaccine in that time period when they're not vaccinated. And younger children tend to have more serious manifestations of illness. And so it's really important for them not only to get it, but to get their vaccines on time. And then there are obviously risks to society for vaccine hesitancy. There are increased risks of outbreaks of the vaccine preventable disease in the general population. So, you know, there are some that are too young, so they can't be vaccinated yet. And so once there's an outbreak in the community, they are at risk. And also the immunocompromised people who maybe they are personally vaccinated, but they haven't responded and they're at higher risk. And then there's also drain on public health resources for testing, contact tracing, and control measures once there is an outbreak that could have been prevented with appropriate vaccination. So what can we do about this? You know, obviously we're concerned about vaccine hesitancy, and I think it's similar to what's been talked about. It's really based on relationships. It's important to maintain positive dialogue. We need to identify and understand parental concerns. You know, maybe they have valid concerns we need to understand. And it's really important to educate the benefits of the vaccines and the limitations so that they know really what they're expecting to achieve from the vaccine. For example, getting an influenza vaccine is not going to prevent you from getting a cold. And so, you know, that is caused by a different virus. And so parents need to know what their expectations are going into it. They really need to understand realistically the vaccine safety and adverse events. The risks of natural infection. I think that often, you know, they have so many concerns about the risk of the vaccine, but they are not aware of the risks of natural infection. And if they really knew what would happen to their child if they were infected, they obviously would make a different choice. So it's important that we make sure that they have that information and correct all misconceptions. And it's really important to maintain a relationship. So I just have this quote that, you know, if at first you don't succeed, try and try again. So, you know, maybe they say no the first time, but you continue to talk and educate, and hopefully we can have improvement in vaccine hesitancy. And then I wanted to move quickly to monkeypox, which, as I said, is really topical right now in the community, but hopefully not impacting our school-age children, and hopefully will not, at least not greatly. So monkeypox, you'll see in the blue dots, these are areas in Central and Western Africa where there are typically epidemics and outbreaks. You'll see in the gold areas, the areas that are now experiencing outbreaks. So you'll see really the global nature of the outbreak. And just recently, Wyoming in the United States reported a case also, so all 50 states in the US do have monkeypox cases reported. You'll see the global case count, and that's actually even gone up. As of this morning, the reported global cases were 45,956, so even higher than when I made this slide. And in the US, we are now up to 16,514. So really things are going up, and you'll see over on the right how much the United States is really leading. All of the other countries, the second country is Spain, they started to plateau a little bit. We are not seeing that plateau in the United States yet. Our cases are really still going up, unfortunately. Here in the state of Texas, you'll see that as of this morning, we had 1,281 cases, still predominantly in men, very strongly, and we're seeing it predominantly in men who have sex with men, although not exclusively. You'll see the age range over here. There have been a handful of cases in those under 18. There also have been a few cases in people over 60, but we're seeing it predominantly in people between 18 and 60. And some of the reason we think we are seeing it not so much in people over 60 is some, at least partial protection from previous smallpox vaccination. And we'll talk a little bit about smallpox vaccination here in a second. You'll see here at Methodist, this was this weekend we had detected 39 as of close of business yesterday. We now have 45 cases detected here in our system at Houston Methodist, with about a 40% positivity rate of our testing. So that's a very high positivity rate for a test. So we really have a lot of cases that we are seeing and managing here in our system. So just some basics about monkeypox. It is caused by the monkeypox virus. At least currently, I'm sure you've heard that the WHO is accepting names and nominations for a new name for this virus. So it may be called something else in the near future, but currently it is monkeypox. It's an orthopox virus. It's in the same family as the smallpox virus, and vaccinia, which is the virus that is used for the smallpox vaccine. There are two different types that you may have heard about. There's the West African and the Central African, also known as the Congo Basin. They have now being referred to by Roman numerals, so clade 2 is the West African and clade 1 is the Central African. And our current outbreak is related to West African or clade 2. Monkeypox was first discovered in the lab in 1958, but the first human case was not identified until 1970. And it is thought that African rodents and non-human primates harbor the virus in between outbreaks. It is a double-stranded DNA virus of the pox virus family. You'll see here kind of at the top, it's with vaccinia virus and cowpox virus. Monkeypox virus is very closely related to those. There have been sporadic outbreaks that have occurred since the first case was described in the DRC in 1970. There have been travel-related cases that have occurred, in other countries from endemic locals, but person-to-person spread has been inefficient. We had several cases in the United States in 2013 related to prairie dogs. Now this current outbreak is behaving differently, and person-to-person spread is really driving the current outbreak. Transmission from animals can occur by being scratched or bitten by the infected animal, or by preparing or eating the meat or using products from that animal. The person-to-person spread is predominantly happening with direct contact with the infectious rash, the scabs or body fluids. It also can happen with prolonged exposure to respiratory secretions with prolonged face-to-face contact. Fomites, that means it can actually be transmitted by touching blankets, surfaces in rare instances, and then vertical transmission from the mother to the fetus through the placenta. The incubation period after exposure is anywhere from 5 to 21 days. It's an average of 1 to 3 weeks. It usually starts, like a lot of viral syndromes, non-specifically with the fever, you don't feel very good, a headache, and some swollen lymph nodes, and then the rash will usually follow that prodrome. Some people in the current outbreak really don't even have that prodrome. The first thing they notice is the rash. Classically, the rash will start in the mouth and face, and then it will spread to the extremities, including palms and soles. In this current outbreak, a lot of patients are having rash that is confined to the groin and genital area. The lesions kind of progress through very different phases, so they'll start out kind of like flat red spots, and they'll become raised, then vesicles, the little fluid-filled lesions, then pustules and scabs. It takes about 2 to 4 weeks to progress through all of those stages, and unfortunately, a person is infectious the whole time that they have that rash and until the scabs fall off and fresh skin is evident. So, it's a long period of infectivity. It is a self-limited disease for most people. There are some risk factors for more severe disease, and in this case, age is really not on your side. The children are at risk for more severe disease, and then obviously people who have underlying immunodeficiency, who are on immunosuppressive medications, transplant recipients, receiving chemotherapy. We're concerned that they will have more severe disease as well. Some of the complications for monkeypox could be bacterial superinfections of the skin at the site of the lesions, encephalitis, infection in the brain, pneumonitis, or some ocular infections. As far as the prognosis, the case fatality rate really varies by the clade. The Central African clade, the clade 1, tends to cause more severe disease, and the case fatality rate's been reported to be around 10%. The West African clade, which is associated with the current outbreak, tends to cause milder disease, and that case fatality rate has been reported to be 3 to 6%. We are not even seeing that high of a fatality rate currently. There have been rare deaths reported thus far in the outbreak, and it's an evolving situation. So when we look at monkeypox, you'll see that, obviously it's really going up now, but even before that, in the 1990s, we started to see a marked increase in the number of both the Central African and West African clade, and that has continued to increase throughout this millennium. And so why? As I mentioned, we think that protection from prior smallpox vaccination is waning now that people are not receiving smallpox vaccine anymore, and also related to growing human populations, there's increased interface and overlap of people and animal populations, humans with each other, and civil unrest in some of the endemic areas. So the way that you make a diagnosis, just like COVID, with the PCR test, so PCR is the gold standard. You take a swab of the lesion and then run the PCR test, and that's how you would make a diagnosis in real time. We can do serology, which is antibody testing, a blood test, to see if somebody has had monkeypox before, but that's not helpful whenever somebody presents with the fever and the rash because they have not developed the antibodies yet. So that is more to evaluate a large group of people to see if they have had it rather than to see if they have it currently. So what can we do for people who have monkeypox? So we have vaccines, we have antivirals, and immunoglobulin. We can talk about that quickly. There is the older smallpox vaccine, and that is available for the prevention of monkeypox also. And that's administered by scarification, where you scratch the skin with a needle. And that one is associated with more side effects, fever, enlarged lymph nodes. You can't give it to people who have eczema. They can have severe and even fatal disease from it. You can have severe disease and transmit it to other people, infection in the brain. There has been reports of myocarditis and pericarditis. So this is a vaccine that is associated with more side effects. And this is not the vaccine. When you hear people talking about a vaccine with monkeypox right now, we are talking about this one, which is a newer vaccine. It's the modified Vaccinia Ankara vaccine, also known as Jynneos. And it's really improved as far as the safety profile. It is live, but it is non-replicating. So you can't, if you've been vaccinated, you cannot transmit it to anybody else. It was licensed by the FDA in 2019 for the prevention of both smallpox and monkeypox in people who are 18 and older. And so instead of being given by scarification, traditionally it's been given by a sub-Q injection. Just recently, the FDA came out with studies and said you can also give it intradermally. So sort of just under the top surface of the skin, like one of the older TB skin tests. And you can give a lower dose, and so it's actually 1/5 of the dose, and that's helpful because I'm sure you've heard we really have a shortage of supply of this vaccine, and so if we're able to vaccinate 5 times more people with the doses we have, that's really quite helpful. It's a very effective vaccine. Animal data shows that it's immunogenic when given as pre-exposure prophylaxis. When we look at antibodies in over 3,000 people in the United States, we see that almost 100% of them actually develop antibodies neutralized after the vaccine. So it's really, really good. There are not a lot of studies that show how effective it is when given after exposure to the virus. That's the post-exposure prophylaxis, which is how it's being used predominantly currently. It has an excellent safety profile, even people who have eczema and other skin disorders, or people who are immunodeficient. So you can give it to all of those people. It hasn't been studied in people who are pregnant or breastfeeding or in those under 18, but can be considered to use even in those patients in the emergency setting. The only people you can't use it in absolutely are people who have any serious hypersensitivity to any of the components. Side effects would be injection site reaction, so kind of a sore red arm. Yeah, some people can have headache and muscle aches and swollen lymph nodes transiently after the vaccine. So there is this risk profile to see who actually would qualify for receiving the vaccine right now. So people who have high risk exposure, so if you have exposure to a confirmed case of monkeypox, and so that would be a sexual exposure, close intimate contact with the rash. For healthcare providers who are in the room when there's an aerosol generating procedure going on with the patient and not wearing an N95 mask and the appropriate protection, that is a high risk exposure. Intermediate risk exposure would be a prolonged exposure without wearing even a surgical mask. If you were wearing gloves and taking care of the patient but not a gown and your clothes touch, that's intermediate risk exposure. And then there are some public health risk exposures. So that would be people who are 18 and older who are on medications for pre-exposure prophylaxis for HIV, if they've been diagnosed with gonorrhea or syphilis in the last 3 months, or if they've attended a venue where they had anonymous sex or exchanged sex for money, then in those type of situations, then they also are public health risk exposure and would qualify for the vaccine. So for people who actually get monkeypox, we do have treatment. We have some treatments that are typically for other viruses, for cytomegalovirus, that's cidofovir and brincidofovir, which also show some activity, we think, for monkeypox. And then there's a more specific orthopox antiviral, and that's the tecovirimat, which is also being referred to as TPOX. And then just like we gave IVIG for COVID, you can also give that for the vaccinia immune globulin for monkeypox. And as I said, in the interest of time, we'll go quickly, but cidofovir and brincidofovir are antivirals that are really used for CMV, but they do have some activity against monkeypox and can be used particularly in conjunction with other treatment strategies for people who have severe disease. The drug of choice right now for people who have more severe disease is tecovirimat, or the TPOX. It is a specific antiviral for smallpox. It has activity for monkeypox also. It targets the orthopox VP37 envelope wrapping protein, and that is really important for the virus to actually disseminate within the body and cause infection. It's available through expanded access from the CDC, and it can be used, as I said, in combination with other therapies, including cidofovir and brincidofovir for severe cases. Side effects from TPOX can be headache, nausea, and vomiting, some abdominal pain, and low blood sugars. And it is available both in IV and oral formulation. And so we consider for treatment, as I said, monkeypox, it tends to be self-limited for most people, and not everyone with monkeypox requires antiviral therapy, but people who have severe disease like encephalitis, people who are at risk for severe disease if they're immunocompromised, pediatric patients, pregnant patients, or people who have severe complications, then these are the patients that really TPOX is indicated for and being given to at this time. And that's all I have. Thank you.
Well, thank you, Dr. Bruce. Really appreciate that. You know, I can't help kind of thinking of some parallels around some of what we heard. You know, one of my favorite podcasts, I was listening to it on Walking the Dogs last night. It's called Cautionary Tales, and they were telling a story about NASCAR back in the 1970s, I think it was, and they had developed all the protection for people, you know, basically their bodies as they drove, but they hadn't done anything for the head and neck. And they were basically this string of people who were dying because essentially their head separates from their spine. And somebody came up with the brilliant idea of head and neck protection. And nobody wanted to use it. They were too tough to do it. They wouldn't do it, all that kind of stuff. And then, unfortunately, Dale Earnhardt Sr., a very famous driver, died from that. And all of a sudden, everybody wanted to do it. And I can't help thinking we've kind of done that with concussions. I mean, when I was a kid, it was like, get back on the field, suck it up. And we saw that in the NFL. We saw that in many other places. We've done that with concussions, right? Bullying, when I was a kid, I mean, I got bullied. Everybody got bullied, right? It was suck it up, maybe go back and fight with them on the playground and stand up for yourself, right? And, vaccines, one of the greatest inventions of humankind, and we can't figure out how to assess the risk. And now we've got people saying, oh, suck it up, go get your chicken pox because there's no risk, and all those kinds of things. So I don't really have a question for y'all in that, just a point of that commonality, but kind of tying with that, I think we as adults, for our kids, need to set the right culture, kind of what we were talking about, and the right example. So one of the things, let me ask you about, that was a question that came in, was a lot of bullying behaviors get passed on generation to generation. I mean, we see bullying in adults, there's no question, right? And oftentimes our kids are just parroting and modeling what they see. So talk about our responsibilities as adults, and talk about, if that's kind of a trend that's seen, what could a family do if they're seeing that? What could a group of people do if they see that?
Yeah, it's a great question. Absolutely, we're learning from the people that we look up to. We're learning from the models around us, and so it makes a lot of sense that we see and we do. As adults, I think it's very similar to what we want to teach in our kids. What's going on inside of us when we get angry, when we get upset, when someone says something? How are we tolerating that? How are we holding that? How are we letting our emotional response then influence our behavior? And I think the important thing that we need to practice and cultivate is the slowing down, is the paying attention to what's going on inside of us, is the understanding what's motivating that. Can I hold this anger? Do I need to be impulsive, and do I need to say something? Or can I actually sit with this and understand it first? Again, that mentalizing, that curiosity, that sitting with as adults when something happens that makes us upset. When we're able to do that better, then we know that we can choose a right behavior and a right response and action. So the same thing that we're wanting to teach our kids in right behavior, we want to also be applying to ourselves and doing. And it goes the other way too. When we're not able to control our temper, when we're mouthing off, when we're being a jerk to someone, they see that too. And they say like, oh, okay, I can do that. Well, why would I listen to you about being curious and mentalizing and being patient and kind when you're not doing that? And so we have to set the standard and hold the standard for ourselves too. It's really important, and oftentimes we don't do it well.
Well, thank you. And let me kind of ask you a related question on concussions. I mean, one of the great things we see when I talk about that culture change is concussion protocols in sports. And we're now modeling it at the pros, right? So the kids will watch TV, they're watching the NFL, they're watching soccer, they're watching, whatever sport, basketball, places where we'll see more common concussions. And they're seeing a player get taken out of a game because there's a rigid protocol. Is that something all high schools and other kids' sports have put in place? If they haven't, what do we need to do to change that?
Yeah, that has. The culture really has changed. And when I first got into concussions, nobody wanted to listen to me. Coaches, nobody. And then back in the 2000s with the LIVESTREAM law out in Seattle, where that was the first state law put into place after someone died on the football field, then the NFL got involved. They made it important that every state pass a concussion law, and now it's filtering down. So it was a large grassroots effort that has made a significant change. Now I have pro players, we have college and high school kids reporting concussions to us after a game that we never would have had in the past.
Well, thank you. Dr. Drews, kind of trying to combine some questions that came in ahead and some that are coming in across the wires here. Do we need to start thinking about vaccinating our kids and ourselves against polio now that it seems to be coming back? Does it change any practices for individuals, I guess, really, who have already had their vaccines as a primary series as a child?
Yeah, that's a great question. I actually had a cardiologist ask me about that as I was riding in to work, the elevator to work today. So if you have been fully vaccinated for polio, you are protected, and you don't need to revaccinate at this time. Similarly to our children, if they have been fully vaccinated according to schedule, they are protected. So it's really just those individuals who have not vaccinated their children according to schedule that now would be an ideal time to go ahead and get on the vaccination schedule and get started.
Great. And another question about flu vaccine, COVID vaccine. Are we expecting those in certain age groups to get added to? The way they read it was recommended, like other vaccines, but I think what they meant really was required, as they ask about other vaccines being required.
Nothing would make me happier. I mean, obviously they are very beneficial to children. They would really help the children both with their illness and also in their ability to attend school, and work and other things. We certainly see with flu vaccines, the higher the vaccination rate, the lower the absenteeism. So kids would be able to come to school, they wouldn't be sick, they wouldn't be transmitting it. But I think that schools are still struggling to get the recommended 7 vaccines that I showed you to get a high compliance with that. So I have not heard any strong movement to add those to the recommended vaccines right now.
So we've kind of put in place a social contract, I think, around concussions, right? It seems like to me we're kind of getting there with bullying. We're not all the way there, but no question. I mean, when my oldest kid was going through school, I don't think we ever heard about it, and now we hear about it all the time. With a 10-year gap, your 18-month-old will be hopefully have really all the best practices in place. Vaccines are a social contract. I mean, if we have a school and we allow a lot of children to opt out of being vaccinated, they're putting their fellow students at risk and themselves as well.
Yes.
Correct? So, it's fascinating as I look at that map. Because the kind of really organized anti-vaccine movement and the states that have kind of the, almost opt out for any reason kind of thing, if you really want to, come from kind of deep red to deep blue. And it's really kind of strange bedfellows across some of those states. And a lot of the states that are more purple seem to only have the 2, And
Right.
so it's obviously I'm generalizing for sure, but how do we change that dialogue? I mean, we've been pounding our head against the wall with this, with COVID. COVID has actually ended up being, very negative, as you talked about a lot of things, but it's been very negative around vaccines. And now we're starting to pay the piper. We're seeing polio. I never thought we'd see it again in this country, other than a traveler from a few hot spots around the world, and that was it. How do we change that? Because it seems like we are, kind of beating our head against the wall on that.
Yeah, I agree. I don't have the magic bullet answer to that. I agree that with COVID, we have taken a step backwards with overall vaccination, unfortunately, and we really need to reverse that. And we want to continue the dialogue, the education. I think it's really extremely important, as I said, for people to understand the severity of the diseases they are trying to prevent. I think that often they are so focused on all these real and imagined things that are going to happen from the vaccine, and they are not focused on what can happen from the infection. So I really think that's a very important thing to focus on.
Dr. Podell, you have some thoughts?
This is a general concept. Whenever you have radical change, it's a top-down approach. You want culture to change, it starts at the top and it has to come down. Our government officials have to start mandating some of this stuff. At first, seatbelts. Nobody ever wanted to wear seatbelts, and now it's a second thought. Nobody thinks not to. Well, most people don't think not to. And in our society, that's how it works. It needs to start from a top-down approach if we want to do a grassroots change in attitude.
Well, so I want to change gears a little bit, but one of the interesting things you talked about was how really kind of a punitive environment didn't work. I mean, again, I find this, patient safety and safety issues, when we're punitive with people who report and speak up, even when they make a mistake, you'll never hear about it again, right, from them. And it's a big fundamental of pushing a safe environment, but a big fundamental, what you're saying in pushing a non-bullying environment, is having really not the same level of punitive as before, but there must be consequences, I assume, for the bullier. So how do you kind of, for the bully, how do you kind of finesse that? And then are there boot camps, was one of the questions we got, or other programs when there is a child who's identified as somebody who is bullying others?
Yeah. So like you were talking about, that zero tolerance against bullying was ineffective, it was not helpful. And we actually saw that when kids were being suspended and expelled, there was a link to the prison pipeline. And so it really was something that we're trying to pay attention to and move away from. And what we're moving toward is more this risk prevention type of idea. What that looks like practically for our kids, it just depends on what they're doing. So I think what our schools are trying to do, they all have policies and procedures in place, so be aware of them, know them, look for them in your specific school. For public schools, I know that oftentimes they're meeting with the bully. Once they actually find out that the bullying has occurred, and we know that that happens quite infrequently, but once they do find out, a school has to respond within 3 days. And so they need to address it within 3 days. And the way that they address it really depends on the level of severity. So it can be to the extent of expulsion or suspension, but really we're trying to meet with the bully, meet with the victim, because bullies are people too. They have things going on. There's probably a reason why they're behaving in the way that they want to do. So we want to understand, and we want to have appropriate natural consequences. It's not like they can just go around keep bullying people. So there are appropriate natural consequences, but it just depends on the type of bullying that's occurred.
Great. Well, thank you. And then one last question that we got in, and then I need to move us on, but Dr. Drews, it's a very good question right now, and I've been asked by patients of my own. And there's a lot of discussion in the medical literature. So we're obviously seeing monkeypox primarily spread now in men having sex with men. Does that make it a sexually transmitted disease? Is it actually taking on characteristics similar to things we classically think as a sexually transmitted disease now? Is it really just, obviously very, very close proximity, and it got into that population first and likely will go into other populations of people over time as other diseases have? Parse that out a little bit for me.
Yeah, that's a great question, and obviously one that is being studied very closely right now. And it has not been, monkeypox has not been clearly defined as a sexually transmitted infection yet, although that may be one of the modes of transmission. They have done studies that have shown that in men with monkeypox, up to 70% of them do carry the virus in their semen. So it certainly seems, a plausible mode of transmission. There have also done further studies, and not all of the men, even in the men who have sex with men, that have acquired monkeypox actually had sexual intercourse. So it is also just close, intimate contact that can transmit it. So it really is contact with the lesions. So while it may end up being a sexually transmitted infection, that is not going to be the only mechanism of transmission for sure.
Great, thank you. Well, I want to thank all three of our panelists for a very engaging and interesting and fascinating discussion today. I hope it's helped y'all with some issues that are tough to deal with as parents, and really tough thinking about how we keep our kids safe and how we promote their health and wellness in every way. I want to give you now a quick update on a couple things around Houston Methodist. Got to give you a little bit of COVID at the end. I'll try and keep that really short, but I mostly want to focus on some exciting news we had again this summer, and kind of talk about it a little bit philosophically as well as how we think and how we move things forward. And that's U.S. News and World Report. I'm delighted to say we did extremely well, the best we've ever done in U.S. News this year. To put this in perspective, there's about 4,500 hospitals in the country that are eligible for ranking by U.S. News. Only 20 make the honor roll, and so obviously very proud of our teams. It's really an acknowledgement and recognition of the kinds of amazing people I'm sitting here at the table with today, and countless others here in our institution who really come to work each day thinking about, how do I make the world better, how do I help people, and how do we help bring healing and care and compassion, and help people during times that are very difficult and times with a lot of suffering. This is kind of our chart of our honor roll status. They tweak the methodology almost every year. We made it for the very first time in 2009, and then back then you couldn't tell where you were, so we dropped off. We were just number 20, right at the top 20. And I don't know where we were because they didn't publish those data, but really starting in 16, now you know where you are. And so really every single year since 2016 now, we've been in the top 25, and as you see now, 5 years in a row in the top. Now, I'll talk about it a little bit later, but I'm going to say it now. What I preach over and over and over again to the teams is it's all about the fundamentals. It's about unparalleled safety, quality, service, innovation. It's about doing the amazing work these folks are doing. Then the awards are really nice. It's great to to celebrate them. It's sort of a rallying cry and an opportunity to pause and acknowledge people for their tremendous work. But this isn't about the end all be all is the awards in any way. U.S. News is actually not the best metric out there, but it is the metric we kind of deal with publicly. It's the same thing for university presidents and universities. I think if you ask just about any university president, they'd basically tell you they have a love-hate relationship with it. You pretty much ask anybody like me, and we'd probably tell you the same thing. It has aspects that are good, aspects that aren't. It does take into count some fairly good quality of care metrics and patient satisfaction or centeredness kind of metrics, some outcomes metrics increasingly, which is really good, and I applaud them for that. It's still stuck, like the college one, on a lot of reputation, which is really hard to measure and really, I always tell people with universities, it's like, well, do you think anybody's not going to rank Harvard in their top couple? I think they deserve it, right? But they've also got a lot of sort of inertia there in kind of how they do some of those ratings and a lot of other dynamics at play. We had a great year, as I said. Here's a few of the summaries. I'm going to skip over this real quick and just kind of look at the honor roll. It is a group of really great hospitals, and we feel very privileged to be there with them. We went from 16 to 15 this year. Not a single entity changed in the top 20 this year. They're shuffling around a little bit, but it is the same 20 this year as last year. Here you actually see our different specialty rankings over the last number of years. Really our kind of highest performance ever. We had 2 in the top 10, which we're thrilled about, a number 8 and a number 9. So GI with our Underwood Center is our highest ranked specialty at number 8. Diabetes is number 9. It's been as high as number 8 before. That one is all based on great outcomes data that you see here. And then you can see the tremendous performance. Most of our others are in the teens. And so again, really excited and proud about that. Really the only specialty that I think we should be ranked in and will be ranked in again and have been ranked in the past is ear, nose, and throat. We kind of keep bubbling in the 50s. And you can see we made it back in the top 50 a couple years back. We'll be back. There's a lot of complicated reasons for that, kind of in how they collect some of the data. It's actually, I think, a great service, but nonetheless, it'll be back there. The others that you don't see us in, we're probably never going to be in, quite honestly, because they're 100% reputational based. And if you're talking about psychiatry, you're talking about, full-fledged, whole-scale psychiatry hospitals, or if you're talking about ophthalmology, taking care of eyes, you're talking about a full-fledged ophthalmology hospital, neither one of which we represent, and they're 100% based on what's the reputation score, so they don't even have that good a methodology behind them, but very, very pleased and proud at what this indicates. In the state of Texas, where we're now number 1 year after year after year, which we're very proud of, a lot of props and kudos to UT Southwestern. It used to be I would have said Dallas really didn't have an academic flagship kind of hospital. Southwestern was a great medical school, but without kind of the hospital structure. And over the last 15, 18 years, they've been building upon that and brought a hospital, folded it in, have been growing, and to their credit, getting some great results. So we're watching them. They're kind of nipping on our heels. Most of their scores are lower within the top 50. They're well below us in terms of the honor roll rankings, but nonetheless, a great institution. Have lots of great things to see. You can see in Houston here, of course, MD Anderson continues to do extremely well. Kind of in any of the specialties, it gets driven a little bit by your cancer ratings. They, of course, are up there, and of course, they're number 1 in cancer. Kudos to them as well on that. And then you can see a couple of the others here in town and their rankings. If you look on the right, almost every specialty we've got, we are the number 1 in Texas with that specialty. Obviously not cancer with MD Anderson next door, but almost every other one we are. When people ask me about this, it's back to the culture stuff we were talking about, and then it's just a relentless, consistent, and sustained focus. And again, that philosophy of saying this is about the fundamentals, and when we get the fundamentals right, a bunch of awards tend to follow, whether it's U.S. News, whether it's something called Vizient, which I'll talk about in a second, whether it is, best employer status or CMS ratings or Leapfrog or many other things. And in fact, that's one of the things I'm most proud of, is because we focus on the fundamentals, we are just very, very consistent. Here you see those 20 honor roll hospitals ranked in order. So there we are at number 15. And then you see CMS, that's Centers for Medicare Services, which has a star rating for hospitals. You can see a fair number in those now are 5-star. There used to be only a couple of us on that list. Leapfrog, which is an employer group that looks at patient safety and scores hospitals A through F. We're straight A's across our entire system, have been A's for a long, long time. And then finally, Vizient, which is really the metric I watch the most closely. Why? Because Vizient is an organization we work with. It used to be called University Health System Consortium. We all put our data together. We normalize how we report the data. We standardize how we report it. So what we call X is the same as Mass General calls X, et cetera, et cetera. And it really encompasses almost all of the major academic medical centers in the United States. And for years now, Houston Methodist Hospital has been in the top group, and you can see there about, 5 or 6, 7 of them, I think, make that top group. So there's only 6 of us at the end of the day with that type of consistency across those outcomes. Actually, it used to be 2 of us. It used to be Houston Methodist and Mayo. So kudos to others who have really been following and driving that as well. So again, that is how we focus. And it comes down to, the good parts of competition. And that's what I will, unabashedly and unapologetically always say is we are going to compete fiercely when it comes to your care. So when academic medical centers compete on safety, quality, and service, the fundamentals I talked about, we as patients, because I count myself among them, we're all the winners, right, as we do that, and it's good for our community. Similarly, when our academic medical centers collaborate, whether it's education, whether it's research, whether it's disaster response, health of the community, our patients win. And so we will fiercely compete and collaborate, because I think there's a little bit of both, but especially collaborate on education and research. And of course, when it comes to things like a COVID response or a hurricane response, we all work together every single way we possibly can. So speaking of that, let me just finish up real quickly. The good news is we are now on, decidedly on the downward slope of this current surge. You can actually see from a wastewater amount of virus, you see the peak there versus this winter. It's actually not that different. It's not quite as high, but it's pretty high, and it was much broader, slower increase, a slower decrease. So there's a lot of virus out there, but it's a different strain that is milder. I think there's no question about that. And the accumulated kind of community immunity is dramatic now. Most of that, and I think the most effective of that, comes from the vaccines, particularly around death and suffering and hospitalization. But of course, it's been hard to escape, getting COVID, and there's a lot of natural immunity that's acquired as well. And thankfully now when you get that with the vaccines in the background and the fact that this virus has gotten a little milder, it's less of a big deal for many people. So that is obviously very good news. Clearly the current vaccines are not working well at preventing infection. Why? Because the current vaccines are based on the original essentially viral template from the beginning. This fall, both Moderna and Pfizer have submitted for a bivalent vaccine. So basically it'll have essentially original strain, and it has BA.5, which is the most recent one in the US. In Europe, they're doing a slightly different approach on that. It hadn't been approved yet. It's going through the process, but we expect that to be approved and available this fall. And we would expect it will do a lot better job on the infection and probably shore us up for, preventing death and hospitalization. I'm guessing that's an annual process here now. We don't know that for sure, but it probably will be very similar to the flu. And in fact, what they're doing now is a little similar to the flu, kind of anticipatory. What's the most recent variant now? We know the vaccines are safe, so now let's update the vaccines. The flu this year is quadrivalent. There's actually 4 different strains in the flu vaccine, kind of doing that same process with that. So with all of that, the result has been actually much less severe at the hospital side. So you can see it's a wide-based surge, but compared to the last 4, it's like, yeah, we got this. Even there, it's if you look at the lower line, the green line, that's ICU. So we've really not seen many very ill patients. And even the blue line encompasses sort of people who are in the hospital for COVID, as well as people who are in the hospital with COVID, who happen to have some other diagnosis. And so this is the good news that's out there, and why we're able to be close to normal, out in the community now. our advice remains the same, which is you got to assess your own personal situation, your own personal risk profile, your vaccination status, your previous infection status, et cetera, as you decide what to do. I'm not wearing a mask most places I go now when I travel, which I just got off a plane yesterday. I wear a mask every time because I'm sitting there in a tube with, you know, a bunch of people next to me, most of whom aren't wearing a mask right now. I have seen a lot of people getting infected who are going on summer vacations and other things like that. Thankfully, they've been mild cases, but they, you know, it is still pretty easy to get. But I think we're now on a nice downside here. Last couple of things, CDC did release some new COVID-19 guidelines. We'll have these slides available for you if you'd like to see them. I'm not going to go into them in gory detail. I guess the couple things I'll emphasize is if you have a mild infection, you know, you kind of can go out into the general public after 5 days, assuming that you're getting to be asymptomatic and you haven't been febrile recently. But what everybody I see is missing is they're just like back in the community. And the guidelines are very, very clear of wearing a very high quality mask, preferably an N95 mask for the next 5+ days, because you may very well still be infectious. And I have seen people I know that I helped with their COVID infection. Then I go out, I see them socially, hey, I'm day 6, how are you doing? And you know, that is the wrong approach. That's how we're giving it to other people. Other very important thing here also, so even moderate or severe or hospitalized disease, it still is a 10-day quarantine to protect other people from that. It does de-emphasize testing as a strategy right now, you know, so you can probably turn that down a little bit, but you know, again, personalize that based on your own situation. Last thing I'll say here is that we have our inaugural golf classic coming up in a couple of months. So we hope you'd love to be part of that. Al Kaplan, thank you very much for chairing that and setting that up for us. We are very appreciative to you. So with that, let me just give you a little bit of information about our next meeting here. If I can find my notes here. It is on Thursday, September 29th. You know, we usually do the 4th Thursday of the month. There's 5 in September. We're going to do on September 29th. We're actually going to do infectious disease at that point. And then in October and December, we will also have meetings on the 3rd Thursday in those cases. And then November will actually be on a Tuesday because it's Thanksgiving month and some other dynamics. So we look forward to seeing you for each of those and hope everybody does well, stays safe, and has a great back to school and a great fall. Thanks so much. Bye-bye.